thanks to Kaio Kekia, I'm here. It was safe. And I'm very happy to be back again in Brazil for this wonderful meeting. So thank you to Roberto for inviting me here. The first talk is about the results, long-term results of total shoulder arthroplasty in primary osteoarthritis. This primary osteoarthritis has been described by Dr. Neer 30, 40 years ago, and this is my disclosure. And we analyzed the long-term follow-up results of total shoulder arthroplasty some years ago with a group of friends in France and in Germany, and we were able to follow more than 500 cases with more than 5 years follow-up. Average follow-up of this series was 8.7 years, so almost 9 years, and we were able to analyze long-term results clinically and also radiological results. We thought that the main problem was, of course, glenoid problems, glenoid loosening, and we tried to understand the why and whether we can improve those results. So if it works, hopefully, I will show you this study. In this group of patients operated starting in 1990, so many years ago, we used two types of glenoid. One was flat back, and the other one was convex back. We also used two different kinds of technique to prepare the glenoid. One was a curettage technique described by Dr. Neer, meaning that we remove the cancellous bone with a curette, and then the second technique we used was a compression technique, meaning that we did not remove the cancellous bone, we just compact it. And we found that there was a huge difference between both techniques to prepare the glenoid side. So this is a series. You see two types of glenoid implants, flat back and convex back, and I spoke already about the series. Regarding the operative techniques, all our cases were done through a deltopectoral approach, usually with a tenotomy of the subscap, and the humerus was cemented. The long head of the bicep was stenoted in more than 50% of cases. You see here the two different kinds of preparation of the glenoid, either the curettage above or compaction at the lower part. Regarding the clinical results after 9 years average follow-up, we found that all the consent score criteria were statistically increased at the long-term follow-up. We had a very good consent score, 83% on a normal shoulder, and active forward elevation was 125 degrees, whereas 86% of our patients were still very happy or very happy. We did another study with a fellow of mine, with Patrick Reis from Germany, with a longer follow-up, and we showed that the consent score improved for the first 2 years after total shoulder arthroplasty. Then there is a plateau until 15 years, and starting at 15 years, we observe some decrease in the consent score. But the patients, of course, are older. Regarding the complication and revision of this large series, what is important to understand is that the main complication was always a glenoid. On the humeral side, we did not observe many problems. And the revision rate was 12% in total, mainly related to the glenoid loosening. And if we want to remember two important numbers, 56% of complication at 10 years and only 12% of revision in the same group. After 9 years, the main problem, the main complication was definitely radiological loosening, when the radiolucent line score was above 12 points, or when we observe a shift of the glenoid component. And again, we analyzed that with Patrick Reis, And with a longer follow-up, we observe the same thing. After 10 years, we start to observe a high rate of glenoid loosening in this historical series. And definitely the glenoid loosening has an influence on clinical results, especially if you consider the group of patients with more than 12 points for the radiolucent line score. We observe that there is a statistically significant influence on all the criteria of the clinical score. So more than 12 points means that there is radiological loosening. It's not clinical loosening, but it's radiological loosening. We try to understand why. So we analyze carefully all our cases with radiological loosening. And we had a series of 170 cases with radiological loosening, and we found out that the length of follow-up, the upward migration of the humeral head, the younger patient, and the curettage technique were all statistically significant for glenoid loosening. Upward migration of the humeral head is not so easy to analyze. We try to follow the Mayo's group in order to distinguish between mild, moderate, or severe superior subluxation. And you saw that we had 25% of significant upward migration of the humeral head at 10 years. And we believe that moderate and severe subluxation are correlated with massive secondary rotator cuff tears. And this is definitely one of the most important factors influencing glenoid loosening. So as a discussion of this series with long-term results, that was the beginning of our experience again, but we learn from experience, we learn from our mistake, and it's a good way to improve ourselves. And we learned that the humeral side is not really a problem in total shoulder arthroplasty, and that we did many surgical mistakes during glenoid implantation. One of the first mistakes is that we put a lot of cement around the keel. This was a mistake because we removed all the good bone. And in the long term, you can imagine that the cement cannot sustain the constraints of the arm. The second mistake was excessive reaming. And you see this example of the patient. For the first 4 years, he had wonderful results, also on the glenoid side. But at 9 years, you see subsidence of the glenoid implant inside the glenoid bone. Why do we observe this subsidence? First of all, because of mechanical cause. Because you have to remember that the glenohumeral joint experiences a wide range of loads, and it's crucial to understand that the cancellous bone cannot resist, neither the polyethylene nor the cement. So we need, if we want to have a good long-term results, we need to have a strong bone support for our glenoid. Influence of reaming is also crucial. We compared the results of different centers with a large experience, and in the center number 3 and center number 4, which were Pascal Boileau and my centers, we used to ream down in order to have a very nice surface of the glenoid bone. And clearly the subsidence rate was extremely high in our center because of that. So excessive reaming of the glenoid should not be done. We must preserve, at any price, we must preserve the subchondral bone to resist the constraint of the arm. So in conclusion, long-term results is good regarding the clinical results, whatever the age. Metaphyseal stability of the humeral stem, rather than cylindrical shape, is a good concept. It allows to have a good long-term results on the humeral side. The negative points of this historical series is the glenoid radiological loosening. And we discover two important things. First, the surgical technique is important. We need to preserve at any price a glenoid subchondral bone. And, of course, we need to correct excessive retroversion or superior excessive inclination. So that is a surgical technique. And there are new ways now to do this kind of surgery, total shoulder arthroplasty, in order to respect these criteria. The second point is we need also to improve the glenoid implant. We have a smaller anchorage and a larger surface contact on good bone. That is what we learned from our experience. That is what we learned from our mistake, helping us to improve our results. Now, another thing is that we cannot comment about the glenoid peg because we do not have long-term data, but I don't understand why the peg should do better than the keel. Because as you understand, the main problem is not the anchorage. The main problem is the surface contact, the preservation of the good bone, the correction of inclination and retroversion. So maybe the long-term results of the peg will be better, but I'm not sure about that, and I'm waiting for long-term results of the peg in order to really to compare these results. Thank you very much for your attention.